Okay, everybody, good morning. Welcome to Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually, you may enter your question into the Q&A section, and the link for your survey will be shared in the chat, so be sure to copy that link before you close out. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the survey and give us permission to do that. And now it is my pleasure to introduce our speaker. Daniel Whitson, MD, is a fourth-year general surgery resident at Northeast Georgia Medical Center. He earned his medical degree from the American University of the Caribbean School of Medicine. He is excited and grateful for the opportunity to give general surgery grand rounds at his hometown hospital here in Gainesville, Georgia. Even though his educational journey has taken him from North Georgia, across the Atlantic to England, and then to the Greater Antilles, it is an honor to be a part of a training program back home. He is looking forward to his next destination in Kansas City, where he will be furthering his passion for vascular surgery as a fellow at the University of Kansas in 2026. Please join me in welcoming Dr. Daniel Whitson.
Alrighty. All right, well, first I just want to say thank you everyone for being here today. I want to thank the faculty. My parents are here, so I appreciate you guys coming. And then all the residents and stuff. You know, it's been a fantastic journey here, and I think I'm happy to be able to stand up here and honored to give a grand rounds at my hometown hospital. So today, Dr. Anderson has already kind of given us a great overview and history and background of cerebrovascular disease and its treatments and history, including carotid stenting. We're going to kind of take that one step further and dive into the newest approaches and how those are being actively studied and implemented here in Northeast Georgia, but also in the country as a whole. So with that, we're going to, like we said, we have no disclosures today. Our objectives are going to be to review the development of the novel transcarotid stenting approach with flow reversal, or also known as TCAR, highlight the pros and cons of TCAR versus CEA specifically in relation to patient populations, describe the recent trends and future directions in carotid stenting, both nationally and here at home in Northeast Georgia. And finally, we're going to discuss associated challenges and solutions for TCAR procedure based on disease presentation. So just to start off, we'll review again, what is TCAR, how does it work, and what makes it unique? So the flow reversal system was originally developed at the University of Michigan in the early 2000s. And the rationale was, up until this point, if you were going to stent the carotid artery, you were going to have to cross a high-risk lesion with a wire or some device to protect the brain. So the thought process was, how can we get rid of that step, which is likely the largest contributor to stroke during these procedures? So flow reversal was the initial technology which was developed. After that, they looked at, okay, well, this is one way we can mitigate risk. Now the aortic arch represents a different challenge. Navigating that with the wire, navigating that with catheters also presents a risk. So in order to address both of those challenges, one, they developed a direct carotid approach to access percutaneously at the common carotid artery. So this means a less invasive surgical incision above the collarbone, directly accessing the common carotid artery with a needle and then inserting a sheath in there as well. Now, at that point, flow reversal is established, which directs the flow back to the femoral artery on the contralateral side through a novel filter mechanism. So with both of these together, we've developed a way to, one, reverse blood flow before any high-risk lesion is crossed, avoid the aortic arch, and as well use a novel filter system to protect the brain or the rest of the body from any emboli or debris. So all in all, it's a very unique and novel procedure. And this, like I said, was originally developed at the University of Michigan. It was then formally developed by Silk Road Medical, which was based in Sunnyvale, California. and now most recently is being spearheaded with its third roadster trial at Centara at Norfolk, or also known as EVMS. So when we just getting into a little more detail about the procedure, here we kind of have an up-close view of what's happening in real time. So basically, here we have, you can see this white catheter is where it is accessing the common carotid. So that's where you're going to be exposing the common carotid. You're going to be getting proximal and distal control, and then you're accessing right on top with the needle, and then following that with the special catheter. You can see the catheter tip here. It terminates before the bifurcation, before you would encounter any high-risk lesion. And then you have a bare metal stent developed by Silk Road, which is then placed into the internal carotid artery. Now, there's different techniques to accomplishing this. There's techniques called stopping short with your wire versus engaging the external carotid. So if you need extra support, you can actually advance the wire to the external carotid before you start deploying your stent system. You can also pre or post dilate with a balloon as well. And we're going to get into some risks and benefits for all of these techniques. And also, what are we doing here at Northeast Georgia? What is our technique been, and have we been successful and safe with that? And here we have this device that looks like a cylinder. This is the filter device. This is where the blood actively flows through during flow reversal. And you can actually program the settings for how much flow you want. So we always start with the high flow reversal. If the patient develops neurologic symptoms, there's a second setting to decrease the flow reversal, still provide protection, but allow a little bit more perfusion. Here we have an angiography before and after stent placement, which you can see a very significant result. You see basically a focal stenotic lesion there, which is essentially disappeared after stent placement. So, just to review the road to standard of care for the TCAR procedure, we've kind of touched on a lot of it already. But, it's been basically developed initially to mitigate stroke risk with transfemoral stenting. But then they found that in high surgical risk patients, which means either comorbidities, anatomical lesions, or high risk for stroke, such as, symptomatic status before the procedure, they found that TCAR specifically offered those patients a better safety profile, and that it was compared to transfemoral stenting and a carotid endarterectomy in some patients. So that's where we realized the potential for this procedure, that patients that were at high risk of stroke could actually be offered a faster, safer, and a durable result with this procedure. Now, since then, they've looked at expanding that to standard surgical risk patients as well, saying, well, does this offer benefit to patients that are not at high risk, that are at a normal risk for carotid procedures? And basically, that is essentially comparing to carotid endarterectomy. And that is actually ongoing right now. We're in the process. They just completed enrollment for the Roadster 3 trial, which is, like I said, is based out of Norfolk, Virginia. And they are analyzing whether we see the same durable benefits even with standard surgical risk patients. And where does that play when we offer patients a treatment options for cerebrovascular disease when we talk about carotid endarterectomy versus a stenting approach? So, I think we touched on this already, but basically TCAR gives the opportunity to provide a better safety profile for certain patients with cerebrovascular disease. And that's really what prompted this to be adopted very quickly and very efficiently into different hospital systems and departments. So obviously they found significant risk reduction for MACE, which is major adverse cardiac events, by 10% for all carotid interventions. And that is compared to centers only offering CEA. So we see a benefit absolutely right off the bat there. Now, we did touch on this as well, but when compared to transfemoral stenting, across the board, it is clear there is a benefit. And although there still remains indications for transfemoral stenting, I think TCAR has replaced a large majority of these procedures for cerebrovascular disease. Now, this illustration, you can see that the aortic arch is prone to plaque buildup, which makes very high risk for emboli during a procedure, especially when you're using catheters and wires that can dislodge those lesions. And so not only does that happen at the aortic arch, it can happen at the origin of the common carotid artery as well as the bifurcation. Again, to reiterate, with transfemoral stenting, there is no way to protect the brain before crossing the lesion. So that's the major point. So again, just to reiterate, when we compare transcarotid versus transfemoral, we see across the board benefits in the stroke rates, in the hospital complications, short and long term. And then, like we said, when we differentiate between high surgical risk and standard surgical risk, we see absolutely benefits in the high surgical risk right off the bat. And you can see based on these studies here, across the board, there are lower percentages for the TCAR group and equal percentage here for TCAR versus CEA. So up until this point, we were seeing some equivalent outcomes compared to CEA. That's why that is going to be our focus going forward, is delving into which patients would be better suited for CEA versus a direct transcarotid approach. And then that brings us to the standard surgical risk patients over on the far side. And you can see, again, we have some relatively equivalent aspects when TCAR is compared to CEA. However, when we looked at the CREST trial, CEA actually had a higher percentage of complications when compared to the SAPPHIRE trial. So based on the decades of research, we've seen equivalent outcomes and especially long-term outcomes with carotid stenting versus CEA. And that's important because the TCAR is a novel technique, but carotid stents are not novel. That's something we've been doing for a long time. So once we place the stent, we have data showing, is it safe for the stent to be there? What happens over the long term to these stents? So that's an important thing to note. And fortunately, we have data for that. Like we talked about, SAPPHIRE trial also showed us that reintervention rates at 1 and 3 years were lower in the stenting arm versus CEA. However, the CREST trial basically found no significant difference. So at most, we have a decrease in reintervention, but also I don't think that has been fully fleshed out. And right now, I think we would probably say that they're equivalent at this point until we get some more data. So now this brings us to our hometown. So what's happening here in Northeast Georgia? We've been actually looking at outcomes and different metrics for this procedure since the first stent was placed in 2019. And it's been very exciting how it's been adopted in our program and how we look to use it in the future as well. So this is a great schematic showing the progression of TCAR cases at Northeast Georgia. We also have a breakdown of which surgeons are doing this, what is our total number, and what is our percentile nationally as well. So you can see a dramatic increase in our procedure volumes at around the 2023 marker. Like I said, the first stent was done here by Dr. Parikh in 2019, and from then on has been adopted by almost every vascular provider. So this data extended to 2024, towards the end of 2024, and at that point we were at 268 procedures. That is 90th percentile for TCAR volumes in the country, and is actually now at this point a little over 300, approaching 400. We have the breakdown here. You can see Dr. Parikh has performed a majority of these procedures, but this is definitely evolving over time. And if we were to redo this graph to this day, it would be a lot more even among providers. So then we get into some more interesting metrics, such as, these are comparisons from our account, the Northeast Georgia account, to the national consensus. So symptomatic status, we are right equal to the national percentage, 63% for percentage of asymptomatic and 37% for symptomatic patients that undergo this procedure. You have the age breakdown here. For our account, we have a larger percentage of the 70 to 74 age group and younger as well. And I think that, there's many reasons that we've talked about that could be. One may be in the Southeast, we may be seeing a atherosclerotic disease at an earlier age. That could be one potential reason, but that's something we can definitely look into further. As far as gender, there's not a significant difference either. Majority of male patients, both here and nationally. And then, so this is where it gets very interesting. So our standard surgical risk percentages. So for our account, 93% of our procedures were high-risk patients. Okay, so that is in line with what the data has showed us up to this point, that this is validated and effective for high-risk patients. Now, like I said, the transition is currently looking at standard risk and the benefits in that population. So nationally, you can see this is already trending in that direction because they had a decrease. They had 70% high-risk patients versus 30% were standard surgical risk. So to me, that means that we've been safe. We've been conservative with our application of this. And until we get this data and final results, we're going to look at how we implement that in our standard risk population going forward. And so here again, we have, let's see, some more metrics here. Gender, we talked about those, age distribution, and symptomatic status. So this is something that is kind of, let's see, that's redundant there. So this slide is also, I think, very helpful. So this is our technical success at Northeast Georgia for all procedures performed. So we have a 98.9% success rate. We only had one case that had to be aborted due to a dissection. And also we have our metrics here, skin-to-skin time, flow reversal time, fluoroscopy time, and the amount of contrast used. And I think it's really impressive that almost all of these metrics are lower in our account based than the national average. So we have a skin-to-skin time of 55 minutes for the procedure as a whole, flow reversal time of only 10 minutes, fluoroscopy time of 3 minutes, and 12 cc's of contrast used for the procedure. So I think that means we're being very efficient and we're being well trained to do this procedure in terms of, our production. So when we look at more procedure info, one is a big aspect of this case is what kind of anesthesia is used during the procedure. For TCAR, it's much more amenable to a less anesthesia. So moving away from general anesthesia, doing it under local, doing it under blocks. But however, at our facility, right now, currently, we still are majorly using general anesthesia. So 93% of our cases are under general anesthesia. And that's something that we're actively looking at too and investigating, whether it's our patient population, whether it's, the way we set these patients up pre-op. That's something that we're going to look into because nationally, 83% approximately is done under general. So wire techniques, we talked a little bit about this, but there's two main techniques for this. The stop short, where no wire is advanced to the bifurcation before flow reversal is initiated, versus engaging the external carotid, which means you're advancing the wire to the external carotid before flow reversal. So we obviously trend towards the engaging the external carotid. And, we don't have a specific reason for this. It may be based on provider comfortability, provider training, and that's something that we're actively looking into as well, because you see nationally, it's actually more common to do a stop short technique, which ultimately is likely the safest way to perform it. And then when we talked about angioplasty technique, we discussed that you can pre-dilate with a balloon, and then you can deploy a stent, and then you can post-dilate with the balloon. So where are we at, compared to national? 39% are getting both pre and post dilation versus 58% are getting pre-dilation only. So most of the time they recommend pre-dilation, placing the stent, and then assessing for the need for a post-dilation based on your angiography. So you can see a slight difference in the national trend, 63% versus 32%, but overall pretty similar. So when we look at our outcomes as far as our stroke risk and, perioperative outcomes, we were right on par here at Northeast Georgia. Our total 30-day stroke risk was 1.6%. Mortality was 1.1% and 0.6% for MI. That is right at, if not below, the average percentages for this procedure. And so that was very encouraging. And one other aspect of why we looked at this is that, this was developed in the academic centers. This was distributed largely in academic centers starting out. So we have very little data looking at our community programs integrating this procedure safely. Are they integrating it effectively? And is this something that can be integrated among the country without, care to be how many volume of cases are you doing? What are the training of the providers? And so this is very encouraging that this procedure can be performed safely in a majority of facilities. So now the focus currently is going to be looking at transcarotid artery versus carotid endarterectomy. So that's going to be what we're going to discuss going forward, the pros and cons and challenges as well. So here we have, some percentages comparing those two from multi-center trials from the JVS. And you can see largely similar, but one thing that stands out is that the significant increase in risk of cranial nerve injury with carotid endarterectomy. And I think anyone who's been a part of this procedure knows that that is what you're most worried about when you're dissecting, when you're isolating the artery during open surgery. And so that is one thing we can mitigate with this procedure that is very promising, as long as we have promising safety profiles in the long term with the stenting. So some surveys were done for the TCAR procedure versus CEA and to ask patients what was their preference, what was your experience with the procedure, and how did you feel about it? And so largely a lot of them were very positive about their experience. So 99% of them would recommend it. They described less pain, smaller incision, better cosmetic result, and basically a quicker recovery. So I think that's significant, although this is, like I said, just survey data. It definitely shows that patients are having a preference as well. And when we talk about how does this specifically affect the hospital, is there an incentive or benefit for the hospital to include this procedure and integrate it into their cerebrovascular treatment algorithm? So when we look at the time frame for the procedure, obviously we have a significant decreased time frame for the TCAR. 73 minutes nationally at our facility, like we said, around 55 to 60 minutes versus an average of 120 minutes for an endarterectomy. And we know that with more complication or a more complicated endarterectomy, it can be a lot longer than that as well. So that can increase efficiency. OR time we see is definitely associated with cost per minute. And then so you have overall a reduced OR cost compared to CEA, although we will get into how does that play into the actual cost of the stenting versus endarterectomy as a whole. So, these are some benefits that we've seen that makes it efficient, makes it durable, and makes it, applicable to the hospital in terms of cost and efficiency. So when we look at overall cost effectiveness in the long term, a TCAR stent costs anywhere from $10,000 to $14,000 for the procedure as a whole, not just for the stent, but including everything. But the 5-year total cost is around $19,000 versus $7,000 for a carotid endarterectomy. Now, they did find a difference in the quality adjusted life years, so that's something that they're actively looking at and trying to reduce in order to get that more equivalent and even more efficient. But overall, the 5-year costs were greater, but there was also a larger increase in the quality adjusted life years, and that's directly compared to carotid endarterectomy. So, overall, they found that TCAR was cost effective in 49%, especially at 6 years. So that's encouraging, and I think that will continue to improve. So when we talk about what are some challenges with TCAR, when what patients are you going to be very hesitant, if not, directly, contraindicated to perform that procedure? So one of them is a specific anatomical requirement of 5 centimeter landing zone for your catheter and stent, and that is measured from the collarbone to the bifurcation. If you do not have a 5 centimeter area there, then that's likely going to be a very difficult placement, may increase your risk of stroke and complications, and should likely consider open procedure at that point if possible. Now, one way that this has been mitigated is with synthetic conduits, and this has actually been shown to be very effective and successful when performed. They haven't come out with any specific data yet, but it is definitely being reviewed. And you can see here, it's essentially sewing a graft onto the common carotid to increase your landing zone and that surface area there. And so you can see how that can be very effective based on the schematic there. We see similar techniques with, inserting axillary impella devices in the cardiothoracic department. It dramatically improves the ability for you to insert that device, and also gives you ability to control and prevent hemorrhage as well. So we can see how this would fit into the larger system as a whole without really disrupting the actual circuit. So you're still flow reversing, you're still transferring blood to that femoral artery, and you're just increasing your landing zone there. So that's one specific solution. There are others that are also being developed as well, but that has been the main solution. Now, the other and more significant challenge when it comes to transcarotid artery access is calcifications. So when you have a heavily calcified carotid lesion, they found that TCAR does not give you as adequate and durable as a result, and does increase the risk profile. So one solution that was proposed to this, and this is actually being explored in the peripheral space as well, is intravascular lithotripsy. So using sonic waves to soften or disrupt the calcific plaques in order to place a stent with a better result and less stroke risk. So this was obviously investigated right off the bat to see if we could mitigate that carotid stroke risk with TCAR. And unfortunately, they did find that although they were successful in being able to provide the lithotripsy treatment, that there was a higher risk of stroke TIA than in the conventional procedure or compared to CEA. So that means at this point, we still don't have a great solution to a calcified cerebrovascular plaque when it comes to direct carotid stenting. And that would be a reason currently to pursue another treatment algorithm if that is the case. So then when we talk about, going back and reviewing, how TCAR can be effective and implemented into a program, especially compared to the gold standard of carotid endarterectomy, we have kind of a summary of the comparison, okay? So for carotid endarterectomies, you want to be more aggressive when you have a low bifurcation and a less than 5 centimeter landing zone, when you have significant calcified disease, and when your diameter is greater than 9 millimeters or less than 4 millimeters. And those are just technical specifics for the stent itself. The one other thing was significant liquid thrombus. They found also did increase the risk profile, although that's being studied why that specifically is the case. When you're looking at transcarotid access, a high bifurcation or lesion is a reason to consider TCAR. That also plays into the high surgical risk patient, meaning that in order to perform an open surgery, you will likely put the patient at increased risk of injuring a cranial nerve or increased morbidity requiring, an osteotomy of the mandible, subluxation of the mandible, other things to get access to your anatomy, which maybe could be avoided. When you talk about a neck that is hostile, meaning there is prior radiation, there's prior procedures, all of that can give you an advantage for performing the stent and have a less stroke risk. That includes reoperative sites like we talked about, and also patient preference. And this is really why we looked at this at Northeast Georgia, because when we were, after discussing with the vascular attendings in the clinic, with a standard surgical risk patient, we essentially were not bringing up TCAR with them. We were advocating for the gold standard of open carotid endarterectomy based on the data that we had. Now, what we're seeing now is, do we need to start including this in the conversation with those patients and saying that, we're finding that there is a benefit for you potentially, and is that something that you are interested in based on these risk profile, based on the alternatives that we're offering you? And so I think that's something that is now a lot more prevalent in our discussions with patients. Now, there are, like we heard from Dr. Reeves during a prior SCORE lecture, there are patients that would make you want to be more aggressive about an open surgery and less stenting. One would be patient compliance with antiplatelets and things of that nature. Although both procedures initially should have some sort of antiplatelet therapy, what we discussed is that it is higher risk for a patient with a carotid stent to be non-compliant in the first 30-day period with antiplatelets than after going a carotid endarterectomy. So that definitely should play a role in your discussion, as well as the patient themselves. What is their compliance? Have they a history of taking their medications and following up for ultrasounds and making sure we monitor these? Like we said, we're actually coming now to the 10-year period for these TCAR stents, so that data will be available shortly. Although we know 10-year data for general carotid stenting has had good results, I think we're all very interested to see what that data shows specifically for TCAR itself. So, with all of those things, we talked about the hospital efficiency, we talked about anesthesia use, and so I think we're all looking forward to this Roadster 3 results, which should be coming out shortly, as well as how we're going to mitigate challenges such as calcified lesions and also other anatomical constraints. So, at NGHS specifically, things we discussed, to review is expanding TCAR use to a larger percentage of our standard risk patients based on their profile, their preferences, and their compliance, as well as continuing our longitudinal surveillance of TCAR cases and comparing those with CEA. And, and although that obviously will come out at a national level, I think another discussion is that it's very important for centers and communities such as ours to also look at this data at our institutions and publish those and show that, yes, this is equal to what we're seeing nationally, that there's not only certain facilities that can do this with the safety profile that was published. And we actually did have a chance to discuss this at the Georgia Vascular meeting this past year and was very well received. And they did agree that we need more data from community centers, and we want to know that these are successful throughout the country, not just at high volume academic facilities. And on top of that, one other thing to mention is that, how many cases does this take to become proficient? How many cases does it take to offer that patient that safety profile? And it's actually much smaller than you think. So in order to get certified to perform the procedure as an attending, it requires 15 cases. And that includes fellowship as well. If you get 15 cases in fellowship, then you are licensed to perform that procedure. And they found that even looking at data for surgeons that did not have a significant amount of cases versus surgeons that had a large proportion of cases, they actually found no difference in the safety profile for that. So that means that the learning curve is short, that Silk Road has done an excellent job of providing education and training. Teams have been sent out to every facility to thoroughly train the staff in the steps, procedures. I myself have had multiple opportunities where they have offered me training in the steps, showed me models, helped me work through it. And so I think that also has a large contribution to those results. Now, currently, Silk Road is the only company that is offering this procedure. It's still currently patented, and there are no other alternatives for that. But I think that's something that's in the works as well. I think we're excited to see how other companies adapt to this new technique and what solutions they have to offer as well. And with that, I have some references here that we discussed, and I would welcome any questions or comments. So currently, Medicare and Medicaid do cover this procedure, and they just expanded to covering it for standard surgical risk patients as well. So now, at the same time, we know there is a large burden of healthcare costs in our country right now. We definitely want to mitigate that as much as possible. And so, in my opinion, it absolutely should be considered when discussing this with the patient. Although it may not necessarily affect what they have to pay, it will technically affect the larger cost as a whole. And so I think that bringing that up in the discussion and thinking about that is definitely warranted. Now, do I think that will improve? Absolutely. I think likely we're looking at the most expensive this procedure will ever be right now. It's a novel procedure. It's only produced by one company. And so all of those things allow them to dictate, the price essentially. I know that it's not as clear cut as that, but ultimately I think once we get more companies doing the same thing, once we have more alternatives, that will go down and potentially in the future may even end up being lower. But yes, that is absolutely a warranted concern. There was two different studies, the Sapphire versus Crest, and I'll go back to the slide so we can just see the numbers specifically. But the Sapphire study showed that there was less in the stenting arm at 1 and 3 years versus CEA, and that's the blue trials there, so 0.6 versus 3%. CA being 4.3 versus 7.1. Then the Crest trial showed actually no significant difference. So there is still a question of that, and that I think we're encouraging, hopefully, to see some data with the Roadster 3.
1 and 3 years.
Right. Oh, so you're saying for the 10-year data. Well, that goes back to let's see, the 30-day stroke. I want to say, so I don't have the schematic up here, but it was around, I want to say 9%, 8 to 9%. Yeah. And so that's something that we'll get more data with shortly as well. So I do think that it is absolutely influenced. Like you said, there has definitely been discussion about the Crest trial. And I do think that it warrants a certain amount of concern when analyzing the data, especially when we have specific companies that are dictating the stent that can be used and how you're using it, and not having other alternatives to compare and say, well, this bare metal stent at 10 years placed transcarotid has this outcome. This one has that outcome, and I think until we get more ability to compare alternatives, I agree that you have to take that into account when looking at the data and understanding it. And I think all of us are a little skeptical about carotid stenting in terms of long-term patency and restenosis compared to CEA. When you talk to vascular surgeons, they say, when you finish your patch angioplasty, you can see the increased diameter of that vessel. You can see that there's a significant change that you don't get to see during potentially a carotid stenting procedure. So I think that everyone is skeptical about those results. And I think we were surprised, honestly, a lot of people to see these lower percentages. But I don't think we can rule out that there absolutely are some confounding factors. And even with this Roadster 3, it's exciting. There's going to be more data, but until we have more alternatives and until we can compare multiple different stents and multiple different companies and their techniques, I do agree that it takes some concern, and I think we should be suspicious, absolutely. And at first, there was a stipulation that the facilities performing this had to be registered with VQI and to be contributing to VQI data. And to my knowledge, cardiologists have not yet been approved to perform this procedure. Currently, it is limited to vascular and neurointerventional neurosurgeons. So I absolutely agree with that. Just because you're placing a carotid stent does not mean that any specialty should be able to perform the procedure. It still does require a surgical cut down. It still requires a safe dissection of a very significant artery and knowledge of the anatomy there. So I think that absolutely there should be a restriction, and there should be ongoing data looking at, if we do start developing this in a different specialty, is it being done safely, and are there differences in outcomes after that? So I would definitely say that would be a very beneficial thing to look at. And just to kind of finalize out, the one thing I was going to bring up too that I just was realized that another thing that's making a big comeback right now in the vascular world is drug-eluting technology. So initially it was came out, there was a lot of kind of bad results, mixed studies, and it was kind of pushed back against. It is now making a significant comeback, especially in the peripheral space. And that is something they're starting to look at with carotid stents as well, is does drug elution offer any other benefit in this setting? So I think we're all a little skeptical as well with that because of the recent data, but that's something that may be interesting in the future as well. Of note, Boston Scientific has recently acquired Silk Road Medical, so they are now basically taking that to a broader market and hopefully going to be adding on to the technology and giving us some more data. So we're excited for that. Absolutely. But yeah, I think it's just exciting that we have something cutting edge that we're offering our patients, and we're making sure we're doing it safely. So I think that's really encouraging. And especially with our, demographics here in the Southeast, I think it's very important for us to be aggressive about this. So, and I think the use of dual antiplatelets is something that should definitely influence the consideration of the discussion. And like we said, you have a patient that has not been very steady on their feet, doesn't have a lot of people at home keeping an eye on them, helping them, something you definitely need to consider. All right, well, thank you everyone for listening and coming out.